Right, can you see the book?
Yes.
Yes.
All right, so I was saying the pulmonary embolism can be caused by more than just a blood clot. There are fat emboli, we have air emboli, we have foreign matter also becoming emboli. We have medications, if not given properly, cause precipitates, and those become emboli as well. But chapter 27, the discussion here is strictly for blood clots. So it's the management and care of a patient having a blood clot in the pulmonary arteries. Now, unlike in an MI or a stroke, wherein the blood clot lodged in a coronary artery, cerebral artery. Now, this is not called an infarction. It's actually difficult to infarct the lung because of its anatomy. The lung has dual blood supply, so it doesn't really receive perfusion via the pulmonary arteries, because if you think about it, the pulmonary arteries, the blood that goes in there came from the right ventricle, which is unoxygenated blood. So it still has to get oxygen from the lung and then return to the heart via the pulmonary veins and then comes out of the aorta. So the lung doesn't really receive, I mean, it technically does receive blood in the pulmonary arteries, but remember, it doesn't get oxygen that way because it's the one giving the oxygen. So the lung actually gets its main oxygenated perfusion via the bronchial arteries, which arise out of the aorta. So therefore, when you get a PE, it's not called a pulmonary infarction. It's just called a PE, meaning it. Although there is going to be hypoxemia, because it will result in less blood return on the left side because there is increased pressure in the lungs. So on top of the PE causing hypoxemia, there will also be a decrease in cardiac output. Blood clots usually form away from the the heart and the lungs, although it could also form, as you learned in DVTs, I mean in AFib last semester. So in AFib, besides the loss of cardiac output, there's also clotting because blood is pooling inside the heart chambers. So there are basically three conditions that will promote the formation of a blood clot. We call these conditions the Varicose Triad, and they are venostasis, vessel wall damage, or another term for that is endothelial damage, and finally hypercoagulability. So any one of these conditions will form a blood clot. So let's see where each one of these mentioned in the, although this is not a exclusive, I mean an all-inclusive list. Okay, there are dozens more not included in the list. So any condition that causes venostasis, namely if you're immobile, let's say after surgery, let's say you had hip or knee replacement, for instance, will that impair your mobility?
Yes.
All right, so any condition that will lessen your your mobility. Remember, the only way blood returns to the heart is via muscle contraction. So people who have, let's say, paralysis, let's say after spinal cord injury, whether it's quad or paraplegia, there is no muscle contraction there. So therefore, the only way venous return is possible is if you elevate the legs, right? Or if you do passive exercises on the non-moving extremities. So there would be an endless list of conditions that will lead to venostasis, therefore. So immobility, any person, therefore, who has decreased mobility, let's say you're sitting all day in a chair, or you take long trips, for instance, on an overseas flights, which is to Asia is about 16 hours. So that will be prolonged immobility, not necessarily chronically, but that's a long period of sitting. So that's a lot of venostasis there. Vessel wall damage is any time there is injury to the vessel. So surgery, or if you have trauma, for instance, or if you simply just check somebody's finger, prick somebody's finger to get a blood glucose reading. So any vessel wall damage. So you can just imagine how many vessels we we injure when we undergo surgery. A surgery is same as trauma. There are thousands, if not millions, of vessels, capillaries, arteries, and veins that are injured. So those that will involve a lot of clotting. Hypercoagulability is any condition that will increase the likelihood or will attract blood clots. One such thing is, let's say, smoking, for instance. Smoking, as well as if you have cancer. So that will where malignancy comes in. So in cancer, what makes it hypercoagulable is the cancer cells produce tissue factor, which is the main enzyme produced by any injured vessel. However, in the case of cancer, there is no, even in the absence of vessel injury, meaning there's no endothelial damage, the cancer cells still produce tissue factor for no apparent reason. So it will trigger blood clots. Okay, so there are several conditions, so we can therefore conclude that every patient have to be screened for the risk factor for blood clotting. So every time you admit somebody, you already automatically screen them. They may come in with no risk factors. However, during their stay, will they develop one? Will they undergo venostasis or possibly endothelial damage?
Yes.
Yes,
Yep.
because let's say this patient comes in for a procedure, a surgery. So that will involve endothelial damage, plus there will be venostasis because their mobility will be decreased for a while, right? So therefore, this is a very common condition. The goal here, therefore, is to keep it as a deep vein thrombus. We don't want it to be dislodged and become an embolus. These are the other types. So I only name fat and air and foreign body. We also have amniotic fluid, which can also cause an embolus, as well as tumors. Other matters are, if you remember in endocarditis, there were vegetations that break off, causing the microembolization, leading to um, GI organ obstruction, namely the spleen, the GI tract, even the kidneys. So here are the causes or where conditions that fall under each of the triad. So I mentioned cancer and hypercoagulability, or let's say you're dehydrated, or any of these conditions wherein there is likelihood of clotting, let's say in sickle cell, so you have sickle shaped cells that obstruct blood flow at the joints, and you have polycythemia wherein you have um, double or triple the number of your blood cells in the blood, so making your blood really thick and viscous, increasing the likelihood of blood clotting. Or if you stop taking anticoagulants all of a sudden, and all of these conditions lead to decreased mobility. So that will include burns, pregnancy, and any condition wherein you injure your blood vessels. So what happens in PE therefore is, regardless of the type, whether it's a amniotic fluid, um, air, or foreign matter, or a blood clot, will obstruct circulation in the lung. So therefore, it will be like the blood went to the lung but came back empty-handed. It won't be absolutely 100% no oxygen, because there are several branches of the pulmonary artery. So you have the main left and right pulmonary arteries, and then as you can see in your anatomy or imagine your anatomy, there are several smaller branches going into each lobe. So it's really impossible to obstruct all of them. But if you have multiple, that will be enough to cause a ventilation perfusion mismatch. So a mismatch meaning you have enough ventilation at the lung side, the patient's breathing fine, there's plenty of oxygen there. There's just no circulation, there's not enough circulation to meet that large amount of ventilation, meaning there's good oxygen supply. There is not enough blood supply because it was decreased or blocked by the emboli. Right, so therefore you have a ventilation perfusion mismatch. So if you imagine, this would be like a shunting. There's like a shunting effect because blood went to the lungs, but when it came back, not all of them were carrying oxygen. Does that make sense? Because they didn't get to their final destination. Right? So some of them did not ever receive blood. So when they returned to the right side, they not all of them were carrying oxygen. So therefore, the with every second, every minute that this goes on, the blood oxygen levels drop, and of course CO2 levels rise. Even but the CO2 level rise here will be way later. So your acute problem here is the low oxygen level. So this is where it happens. So imagine this is just one. So if you have multiple blood clots, therefore, it will involve part or all of an entire lobe of the lung. So where do they lodge is simply by chance, wherever they find themselves. And of course, they will end at a terminal part of the pulmonary arteries. It will, because the blood clot, unless the blood clot is big enough to obstruct a larger part of a pulmonary artery. There are three categories of a PE, so therefore not everybody will present with the same classical symptoms. We have massive, which is the most serious because this can lead to shock. We have submassive, which is the most common, and low risk PE, which typically aren't even admitted to the hospital. They'll probably visit the ER, but they probably will be kept overnight or even sent home if it's a low risk PE, meaning the clot is tiny enough and only affects a small portion of the lung. So therefore, they don't need to be admitted. Massive PEs typically are caused by large and multiple blood clots. They are so large that they will obstruct a large branch of the pulmonary artery. Therefore, the larger the branch, the larger also the area of the lung that doesn't receive blood, and therefore no oxygen perfusion. Here are the manifestations. So therefore the treatment will also be a little bit different. Please read on your own the manifestations. They're not really exclusive to PE because they resemble somebody with a heart attack, for instance, or somebody with heart failure. They look the same. They have shortness of breath, they have chest pain, they have difficulty breathing. No, just like a COPD patient coming in with a exacerbation or having an asthma attack. So they all look alike. They will vary based on the category. So if it's a massive, as I mentioned, there will be shock because not only are the clots large, but there are also multiple. So imagine this happening all of a sudden, like this minute, this very second, one or more of these large clots obstruct the one or both lungs. So therefore, there will be a sudden decrease in forward blood flow. there's not enough blood getting to the lungs, so therefore it will also result in not enough blood getting back to the heart. So there will be a sudden decrease in forward blood flow. So of course that will lead to between the right and left, there will be right ventricular dysfunction first, because that is where the blood is coming from, right? That's supposed to go to the lung. So once the um, right ventricle fails, then the left ventricle will eventually follow, because both, of course, will result, because now you have less cardiac output. Not only will the brain and all other organs suffer from low cardiac output, but the heart itself. So this patient may go straight into cardiac arrest. Intervention, of course, definitely we will need thrombolytics. So this patient will be receiving alteplase, just like stroke, to um, dissolve the clot, because we can't wait for the body to dissolve it. So it's not just going to be anticoagulation, but definitely a massive PE patient will require a thrombolytic. Submassive PE, depending again on the symptoms. Typically, submassive will maintain normal blood pressure. The clots aren't that big, and the pulmonary arteries blocked aren't that big either. However, there will still be some extent of right ventricular dysfunction. So there will still be increase in what do you call again the pressure reading on the right side of the heart using a pulmonary artery catheter we discussed last semester. You know,
Is
when
that
we
the
put
Swan
in,
Gans, Professor?
yeah, the Swan Gans, when we put in a Swan Gans, what do you call the pressure reading on the right side?
Pulmonary artery occlusion pressure?
That is the left side. What do you call the one on the right?
Right
Oh,
arterial
shoot.
pressure.
Right atrial pressure or central venous pressure. So your pulmonary artery catheter or the Swan catheter will show you a increased pressure on the right side. So your CBP or your RAP will be elevated. It may also cause the release of BNP, because of course there is stretching of the ventricles here. So the patient could possibly go into right side heart failure, and that will be manifested by the BNP. And if the right side is ischemic enough, it may also elevate your troponin, but not as high as an MI. There will be some elevation. Low risk PE, like I said, these people typically aren't admitted, maybe overnight, if any, because there is really not much problem here. Look at the symptoms. Patient has normal blood pressure, no right ventricular dysfunction, no elevation in BNP or troponin. So these patients will probably be just given oxygen for a while, and given a low molecular weight heparin to go home with. That if anything, that will just be the only thing that will complicate the therapy, is who can give the low molecular weight therapy to them at home. If that's going to be a problem, then that would probably be the only reason they would be admitted. If not in the hospital, then they may go to a rehab facility, now for a short-term admission in a um, skilled nursing facility, just to receive the Lovenox injections. These are the classic signs of a PE. Again, not everybody will present this the same, because it will really depend. What do they have? Low risk, submassive, or massive PE? As already mentioned here, if it's a massive PE on top of box 27.1, of course, this patient will present with severely low blood pressure, so shock level blood pressure, and then definitely increased left and right side heart pressures. You remember obstructive shock, right? Yeah?
Yes.
Yeah, so that was one of the causes, right? A pulmonary embolus. particularly a massive PE causes obstructive shock. Under ABG results, this patient act because of the severe tachypnea. Look at here, you have tachypnea and dyspnea at the same time, accessory muscle use. So the respiratory rate here could easily be between 30 and 50 per minute. So because of that, plus the acute nature of the onset, the patient will present with respiratory alkalosis. That's severe hyperventilation. The hypercarbia here will be a later sign, meaning if this patient decompensates, then that's the only time you will see respiratory acidosis, but not likely during the acute episode. Because I said the patient presents the same way as many other disorders like a heart attack, heart failure, COPD, asthma, it could be anything. So part of the diagnostic testing will involve all those as well. So we will draw just not, not just the D dimer, which is specific for blood clots, but we'll also draw, I already said the ABG, will draw the BNP, we'll also draw troponins, okay, just to rule out what are we dealing with. Here's the respiratory alkalosis I mentioned earlier. The blood test though will not confirm a PE or DVT. However, if the D dimer, and D dimer is a fibrin degradation product, okay, meaning after your body forms a stable fibrin clot, it will begin breaking down that fibrin clot. What's left over after your body dissolves that fibrin clot is D dimer. So the D dimer is the fibrin left behind from that fibrinolysis process that your body naturally does. However, depending again on because our body normally dissolves blood clots anyway, but because obviously the nature of the onset and the extent of the PE is so severe, we cannot wait for your body to dissolve it naturally. So that's why in the case of a massive PE, patient receives a thrombolytic. In the case of a submassive, we have time. We have time to allow the body to dissolve the clot themselves. Now, I don't have to explain to you why we don't give everybody thrombolytics. Why not? Why not just why not just alteplase all these guys' asses? Why
Risk of
not?
bleeds.
All right, so you already understand from stroke. Yeah, alteplase is a very dangerous drug. If you can avoid not giving it, then do so, okay? Because not all people have a very good outcome from alteplase. So we only use it unless we absolutely have to, like in the case of a massive PE, because of the risk. All right, so we already mentioned that we draw all these to rule out other causes. Let's go to treatment. So let's say the patient has massive PE, then there you go. The doctor gives alteplase, orders alteplase, and we dissolve the clot, and then we watch for complications like hemorrhage. Now, for most patients, because I said most cases are submassive, the mainstay is anticoagulation. A reminder though that unlike alteplase, anticoagulants, heparin, warfarin, do not dissolve the clot. So they are, in the case of heparin, it is a thrombin inhibitor. So therefore it stops thrombin from being formed. Therefore, no fibrin will be formed, because you need thrombin in order to activate or form fibrin. So you stop the cascade, the clotting cascade at the point of thrombin activation. So therefore, no blood clots would be formed. So Take note that it will not reduce a clot though, because the clot is already formed. However, it will prevent the clot from getting bigger, or it will also prevent the formation of new clots. Okay, so that's the purpose of anticoagulation, because again, the body dissolves any existing clot anyway, but the way we help the patient is we give them an anticoagulant to prevent further clotting. Okay? And then it'll from there it'll just be a waiting game. Okay, so it's just time. We just give the body time to dissolve the clot naturally. Because heparin has a low half-life, so it has to be given through a continuous drip. During the infusion, PTT, which is the clotting time affected by a thrombin inhibitor, will be monitored every 4 to 6 hours. Standard is about 6 hours. I've never worked for a hospital that does every 4. So the goal is to keep your bleeding time, your PTT, at 1.5 to 2.5 times the normal. It's typically about 80 seconds, okay, between 40 and 90 seconds. And your rate, of course, depends on what was the reading. So your PTT level will determine the, the infusion rate. So no problem. All you do is follow a sliding scale. So it'll literally tell you on the MAR, if the PTT is between this and this, increase infusion by this many, by 200 units per hour. Right? It's anybody can do it. The initial dose, though, is always based on the weight. Typically, it's around 80 kilograms per 80 units per kilogram. So that's your infusion, and then you just follow the titration based on the sliding scale. But don't forget to order your PTT, or don't forget to draw your PTT every 6 hours. Of course, heparin here is for short term. As already mentioned, we can't keep this patient in the hospital forever. So once heparin is started, we have to plan for the discharge. Discharge will, of course, be achieved by warfarin. So we have to start weaning the patient off heparin by starting warfarin so that they can go home. Warfarin is a vitamin K inhibitor. It does not, like heparin, it also does not dissolve clots. Warfarin inhibits vitamin K synthesis. And how does vitamin K enter the picture? Vitamin K is needed to form 4 clotting factors. So therefore, if you have no vitamin K, then you will also have none of those 4 clotting factors. Those 4 clotting factors are just the 4, but you have several clotting factors. However, those 4 are the main clotting factors involved in the intrinsic pathway, meaning therefore, if you inhibit those 4 major ones, then the other clotting factors will be rendered useless. So therefore, that's what makes warfarin an effective anticoagulant. Our goal, this is a PE, this is not a DVT. If it was DVT, the goal of the INR will be 1.5 to 2. This is a PE, so we need it slightly higher. The goal is 2 to 3. It takes approximately 5 days to reach it because the warfarin will only affect future clotting factor formation. It typically takes about 5 days for the existing clotting factors already circulating in the plasma to be eliminated by the body. So typically we wait about 3, sometimes it takes 3 days, 3 to 5 days before we can discharge this patient. If they're lucky, or depending on how aggressive the doctor is with starting the warfarin dosing, we may cut it down to 3, but it's accepted by Medicare, so they'll pay for those 5 days in the hospital. But of course, the hospital always likes to make more money. So the shorter time we keep you in the hospital, the more money we get, because the reimbursement is the same, regardless of how long you stayed in the hospital. All right, we already discussed thrombolytic therapy in, yeah, at least you guys did in stroke last semester, as well as in acute coronary syndrome. So I won't repeat that anymore. But just take note of the danger of thrombolytic therapy and therefore your responsibilities for that. Because it's deadly, remember that the patient must sign consent. Patient or the family must sign consent before receiving thrombolytic therapy to cover our, just in case this patient dies, we are covered. Of course, that's not your job to do informed consent. That's the doctor. If the patient's blood clots are so big, cannot be dissolved by alteplase, then it'll be surgically removed. But that is quite rare. The contraindications, this is what's referred to here, table 27.4, because not all patients, again, will receive alteplase because of these conditions. So absolute, meaning this patient absolutely under no circumstance cannot receive alteplase under here. So history of a hemorrhagic stroke, no matter how long ago the hemorrhagic stroke was, they have an active tumor in the brain, whether primary or secondary tumor. They have a brain tumor, they cannot receive alteplase. It has a recent surgery. How recent? It's typically within the last 3 months, or recent trauma, about 2 months, and then actively bleeding, okay, within the or recently in the last 6 months. If they have, let's say, this one bleeding tendencies, let's say ITP or any other bleeding history, let's say they have, what do you call that, childhood bleeding disorder? Hemophilia. Okay, so if they have
Hemophilia.
yeah, if they have hemophilic, then doctor makes the decision, but it's not an absolute contraindication. Or thrombocytopenia, for instance, or the surgery is in, quite long already. Let's say, plus it wasn't a major surgery, or they had a stroke but not hemorrhagic. So this is absolutely testable, because this is for safety. Because even though you didn't order the alteplase, you're the one giving it because it's given IV. For patients who are likely to have a recurrent PE, we'd rather not deal with it because the patient may not survive another PE. So there will be those patients with high risk for recurrence will be given IVC filters. Or those people who have the absolute contraindications, for instance, or these relative ones wherein the patient has a high risk for bleeding if we put them on anticoagulants. So if they can't receive anticoagulants, then they will be given a filter. This is where they put the filter. It's in the inferior vena cava. There is no superior vena cava filter. There's no such thing. I guess they don't know where to put it. I mean, if you need one, then that means you'll have to put it in several areas. You understand? You get the point? Meaning, if you put it in the superior vena cava, it's impossible to put this on there. So we only have an IBC filter. So therefore, you can see it's not 100% guarantee, because what if the clot forms above the heart, not below? It's a, just like any filter. So these umbrella, what is this? Spokes. Yeah, these arms act like a mesh. So the clots will be trapped here, and then making them good targets for the macrophages and your blood to dissolve, your body to break them down. Here's a summary of your nursing care beginning from onset. As you can see, I did not discuss the nursing care because it's not really different There's nothing new here. Any patient with respiratory problems, what do you give first?
Oxygen.
Oxygen.
Oxygen. So
Oxygen.
yeah, so this one I mean by this nothing different. So you give them oxygen. What else? Do you give them bronchodilators?
Yes.
Yeah.
Yes.
So you give them steroids?
Yes.
Yeah. So no, again, no different from any other respiratory condition. So you do incentive spirometry. You have them postural drainage. You know, elevate their head of the bed. You provide humidification, etc. Okay. The other drugs here is obviously, let's say, which type of PE will require inotropics? Because you learned this in shock. So what type of
Massive.
PE? Okay, so only massive PE receive these. Because remember, this patient with massive PE goes into cardiac arrest, right? They go into shock. So those are, of course, you have to treat those on top of the PE. And as with any other patient receiving anticoagulants, so review your thrombolytic or thrombocytopenia or bleeding precautions. Um, and here are prevention for PE, lifestyle modification. So stop smoking, stay active. Um, if you can, avoid oral contraceptive pills because that's one of the risk factors for hypercoagulability. And that's it. Let's go now to the next. Respiratory failure. This is a... Can you still see me?
Yep.
Okay, I'm still...
It's on the textbook, Professor.
Huh?
It's
What
on the
was that?
textbook. Acute respiratory failure.
Yeah, you can see it, right?
Yes.
Yep.
Okay. All right, respiratory failure. This is a, if you remember heart failure, this is not a primary condition. So heart failure wasn't primary, right? Heart failure was caused by something. Either you had a heart attack, you had a valve disorder, you had a dysrhythmia, you have cardiomyopathy. So you went into heart failure. Okay, so heart failure is a condition. Same thing as acute respiratory failure. This is also a condition. What is this condition? So it's a condition when one or both of the gas exchange functions of the lungs are compromised. Now we have two gas exchange functions. One is the actual oxygenation and the other is ventilation, meaning we have gas exchange at the alveolar capillary level. We also have ventilation, which is the act of breathing. So inhalation, exhalation. So if you have a failure of one, or if both fail, then you are in acute respiratory failure. It doesn't really actually take much. Look at the requirements. Okay. So there are two types, again, because it's either one or both of these functions that will fail. So one function could be hypoxemic, the other function could be ventilatory failure. Okay, so again, type 1 is oxygenation failure or hypoxemic failure. The other one is hypercapnic, or this is also called a ventilatory failure. So one is low oxygen, one is high CO2, but actually both will occur. How they do the type is just the cause that led to it. For instance, an example of hypoxemic or oxygenation failure is pneumonia. So in pneumonia, was there a problem with your rate and depth of oxygenation? Or is it the gas exchange itself that is affected when you have exudate or fluid filling up the lung because of the infection? Which one is it?
The gas exchange.
Okay, there's a gas exchange failure there. So it's fall pneumonia or any other pulmonary condition like let's say cystic fibrosis, for instance. Um, what else? Aspiration of gastric contents, for instance. Those are under hypoxemic failure. We'll look at the causes shortly. And then the type 2, the hypercapnic, is really a failure of ventilation. So let's say I split up with Giselle, and then she decides to take a handful of pills, okay, because of the grief that she's feeling. So she grabbed a bottle. She didn't know what bottle it was, and then she just shoved mouthful after mouthful of the pills. And so she, let's say she OD'd on morphine. Okay, so her respiratory rate is now 8 or 6. So is she effectively doing the act of breathing? Is she able to take in oxygen, and can she, more importantly, can she get rid of CO2?
No.
No.
No. So that's what leads to hypercapnic respiratory failure. So any condition, so one example is just um, the when somebody has an opioid overdose. What about somebody who has a kyphoscoliosis? No, you're hunchback, and then you also have severe scoliosis. Can you breathe effectively if you have that?
No.
No. Let's say you weigh 900 pounds. Can you effectively breathe in and out?
No.
Or let's say you have a normal weight, but then your partner is 900 pounds and you're the one below. Will
You
that
cannot
impair
breathe.
your, yeah, so either you or the partner. So therefore what I'm saying is any condition that will lead to a let's say Guillain-Barré syndrome or myasthenia gravis, right? Can you imagine also them having a decreased rate and depth of respiration? Yes, right?
Yes, because yes.
Yeah. So therefore, there are endless causes of respiratory failure. Now, when do we say that you are in respiratory failure? These are the requirements. Your PaO2 must be greater than, I'm sorry, PaCO2 must be greater than 50, and your PaO2 is less than 60. So and your oxygen saturation is less than 90, and of course you have some acidosis. Okay, so those are the requirements. Your um, you are in respiratory failure if your PaO2 is less than 60, or your PaO2. I say or, okay, because there's two types: hypoxemic or hypercapnic. Or it could be also both, because there is a condition. COPD is uniquely in a position wherein they have both. Because in COPD and in emphysema, they have the alveolar capillary damage, right? They have the hyperinflation of the lung. Plus, they also have chronic bronchitis, which affects the rate and depth of their respiration. So COPD falls under two. So if you have a COPD exacerbation, you'll have both hypoxemic and hypercapnic respiratory failure. But in all other patients, it's an or thing. PaO2 less than 60 or PaCO2 greater than 50, and acidotic pH. But most likely, once the condition progressive, you will have both. PaCO2 is less than 60, PaCO2 is greater than 50. Now we've been discussing this for a few minutes. So therefore, if you look at respiratory failure, can you treat and cure respiratory failure? Can you say definitively yes or no?
No, I mean you put on the
No,
ventilator.
right? Because although you can support the patient, you can put them on oxygen or even intubate and put them on a ventilator. Remember, there were causes that led to this, right? So therefore, you have to resolve the cause first before you can cure this. However, the patient will die if you focus on the cause, because you need to support the patient in the meantime, correct? Let's say here, look at this. One of the causes is PE. PE can cause respiratory failure. And we just concluded PE. Was it easy to resolve PE?
No.
No,
No.
it took a while, right? It takes a while before we can resolve it. So therefore, until we resolve the underlying cause that led to the acute respiratory failure, you have to keep the patient alive. You have to give them oxygen, or if necessary, intubate and ventilate the patient. All right. So the only management of we're talking about respiratory failure, is simply oxygenation. We put them on oxygen, and just like a COVID-19, for instance. So it's the same. So patient with COVID-19 go into respiratory failure. That's why they are intubated, because they are in respiratory failure. So until we resolve COVID-19, they will be in respiratory failure that whole time. That's the reason why we put them on a ventilator. We intubate patients with COVID-19. Right? But then, of course, while the patient is on oxygen therapy, we treat the underlying cause, right? Whatever that cause is. So of course, it will determine how long the patient will be in respiratory failure. Does that make sense?
Yes.
All right. Any question on respiratory failure? All right, so yeah, look at your risk factors. I mentioned some of these already. So for exam purposes, here are your causes, right, or risk factors for acute respiratory failure. Now let's with manifestations besides the ABG changes, which is less than PaO2 less than 60, PaCO2 greater than 50. Oh, by the way, some books say the CO2, PaCO2 doesn't have to reach 50, meaning they already consider you in respiratory failure if your PaCO2 is greater than 45. So either 45 or 50. Okay, so it varies by author. Manifestations, nothing exclusive to respiratory failure, meaning this would be, again, this could be anybody, right? This could be a COPD patient, this could be a PE patient, a heart failure patients. They all look the same. They're all gasping for breath. So nothing really exclusive to respiratory failure. Okay, so it's anybody with low oxygen and high CO2. Those are your signs. Like I said already, the management will be, of course, oxygen therapy. Okay. If we can meet the oxygen therapy by non-invasive means, yeah, we stay like that. Okay, we give the patient oxygen by a cannula, mask, rebreather, non-rebreather, or if needed, put them on CPAP, BiPAP, and then last resort would be intubation. So here's the oxygen, that's your management. So you always go up, okay? You start low from cannula and then go up as the patient's condition, depending on the patient's response. We'll discuss airway management a little later. As I already mentioned, the management also will be nothing different besides oxygen. This chapter, though, chapter 27, will not discuss the management of each condition, because obviously myasthenia gravis was in another chapter, PE was earlier in this chapter, COPD or whatever the cause, they're in their own chapters. So here, as I mentioned in PE, so this patient with respiratory failure, the same thing. Just like any other patient who has respiratory condition, we give them bronchodilators on top of oxygen, steroids, diuretics, all right? Or if indicated, let's say the patient's having pneumonia, that's what led to respiratory failure, then we give antibiotics. And the others are also supportive therapy like humidification, postural drainage, etc. The sedation here is anti-anxiety. The usually we give what are you taking, Giselle? You're on Xanax?
No.
No.
You got some?
Well, I would assume you were already on it. No, just in case the day comes that no, I do really, say I can't see you anymore. But I'm joking, right? Yeah, we're still okay. And that's it, really. That's for respiratory failure. It's simple. Guess your goal here is to give oxygen, keep them alive until you resolve the underlying condition. So nothing new, because you already know how to handle anyone with a respiratory problem. To this day, I know there are literature now going out with bad lung down, but as long as our textbooks still say good lung down, we stay with good lung down. Okay, let's go now to ARDS. Okay, ARDS is still respiratory failure. This is a progressive type of respiratory failure. The number one cause of ARDS is acute lung injury. Now, acute lung injury further has several causes. There are direct lung injury. There is also indirect lung injury. Examples of direct lung injury is pneumonia. Right here we have pneumonia, severe trauma to the lung, of course, aspiration, meaning you vomited and then you aspirated that acidic gastric contents, it went into your lungs, or you have massive transfusions, or smoking, or during heart lung when you undergo open heart surgery and your circulation is um, connected to a heart lung machine, it could cause ARDS or direct lung injury, or you can have pneumonectomy. That's directly um, that's direct lung injury there, because it's surgery to the lung. A PE and overdose of drug or alcohol. So these are your direct causes. There are the most common though is sepsis, which happens in COVID-19 as well. So the patient develops sepsis because after your lung is infected, the lung is very vascular, so it's not hard for the infection to enter the bloodstream. So the patient develops sepsis, and sepsis is a indirect cause of acute lung injury. So you have your direct causes here, indirect causes. So this is now number one. This is the most so if sepsis doesn't kill you, which we talked about septic shock in module 1, you can die from the complication of sepsis or septic shock. You can die from ARDS. Okay. Let's go to the pathophysiology. We won't talk about the phases because there's really not much to test about the phases. The condition though gets worse. Okay, so that's what the three phases talk about. So it goes exudative, proliferative, and fibrotic. Most people though die around the exudative phase, which is about 24 to 48 hours. So for those who survive, meaning they reach the fibrotic phase, they're alive at the fibrotic phase, but remember, this is now pulmonary fibrosis. That means most, if not all of the lung tissue is now fibrous tissue, which is pretty much scar tissue. So therefore, you will have decreased oxygenation capacity, okay, if you survive ARDS, right? So what happens is, where is the, let's go here. Okay, so let's use sepsis as an example. So you remember severe sepsis to septic shock, right? Remember the part where we talked about the increased capillary membrane permeability when there is severe inflammation? You remember that part?
Yes.
Okay.
Yes.
So the increased cytokine activity because of the severe inflammation resulting from the infection increases capillary membrane permeability. So therefore now, so the same thing, this part here looks familiar to you. We read this part um, in uh, in the shock chapter. So the increased inflammation causes capillary membrane permeability to be increased. So now they can allow proteins, which is albumin, to move from the plasma into the interstitial space. And in this instance, the interstitial space, or the extracellular space we're talking about, is the alveoli, because remember, the capillaries around the alveoli become very permeable. So the where else could albumin go? It will go inside the alveoli, and water always follows it, because that will protein helps maintain colloid osmotic pressure. So therefore, if the protein is no longer in the plasma, it's now in the lung, so it will maintain colloid osmotic pressure inside the alveoli now. So now the water will of course follow the higher oncotic pressure. So now water fills, end result is water fills your alveoli. So your alveoli is now full of water. So therefore, one of the characteristics of ARDS is, will they respond to oxygen therapy? In respiratory therapy, yes, there were no mention of this process here in respiratory failure. So respiratory failure patients will respond to oxygen. You give them oxygen, they get better. This one, will this patient be able to respond to oxygen if the alveoli, if not most or all of the alveoli, are filled with water?
No.
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 No, gas exchange is almost impossible here, because let's say um, Jasmine is in the pool. Have you ever farted in the pool, Jasmine?
No.
No? Okay. I know Giselle has, right?
I won't lie.
Okay, all right. So you can fart when you're in the pool. However, when you're on top of the pool, let's say you're sitting on the ledge of the pool, or let's say just hanging at the ladder, you know, the ladder uh, at the steps. So if your butt is above the pool, can you fart into the pool?
No. Yes.
No.
No.
No, it's impossible. So you fart, it'll just float in the air. So same thing here. If the alveoli, which is now a pool pretty much, because it's filled with water, how can oxygen enter the alveoli if the pool is full of water? So oxygen cannot pass through water. However, CO2 can continue to escape, right? So the CO2 may be able to escape because you can fart in the water, but the oxygen cannot enter. So here you have a massive dead space, no opportunity, no way for gas exchange to occur. That's why the mortality of ARDS is very high. So the only way to force that water in there is using a mechanical ventilator, something we call inverse ratio um, ventilation, IRV. Inverse ratio ventilation is, we're going to push the air, the ventilator will push the air over 4 seconds, meaning that will be a really long breath. Imagine inhaling for 4 seconds. Can you do that? Can you take a breath over 4 seconds? You can do it
No.
slowly, but imagine
So,
doing it fast. So only a ventilator can do that. So that's the only way the patient can maintain gas exchange, is to put them on a vent, put them on a mode which is IRV. So the vent delivers a breath at high pressure over 4 seconds. So that 4 seconds there, of course, that will wash out all the water back out of the alveoli and into the capillary, therefore achieving gas exchange for 4 seconds. However, right after, during exhalation, because there is increased capillary membrane permeability, the water goes right back inside the alveoli. However, the next breath comes, we do the same thing. At least the patient gets gas exchange, right? But not without the ventilator, obviously. So now, because you have all this water, of course, your alveoli will lose surfactant and therefore will collapse. So another reason why we have to intubate the patient. So you have positive pressure keeping your airway or your alveoli open all the time. This is a cardinal feature of ARDS, non-cardiogenic pulmonary edema, because the pulmonary edema in ARDS, pulmonary edema in PE, pulmonary edema in heart failure, any other condition, pulmonary edema is pulmonary edema. However, the difference here is in how the pulmonary edema formed. Now, if you recall in PE and also in heart failure, how did the pulmonary edema form there? Was it the same way as ARDS? How did the water enter the alveoli in heart failure? Was there increased capillary membrane permeability? Did we ever
No.
talk?
No.
It was a different process, right? So here in ARDS, we know how the water got there. It was because of the capillary leak syndrome or increased capillary membrane permeability. So proteins leaked out, water followed them. That's where the water ended up there. And all these are triggered by the inflammation caused by sepsis or any of the other direct or indirect lung injury causes. Now, in heart failure, how did that water enter the lungs? The answer is right here. How did the water
It's backed
enter
up
the
from the
lung?
venous blood system.
Okay, so there is congestion in heart failure. So the increased pressure in one or more heart chambers caused the leaking. It pushed the water out of the vessels. It pushed the water out of the pulmonary arteries and um, into the alveoli. Okay, it was the increased pressure, it was the congestion that caused it, not increased capillary membrane permeability. So the main difference here is if this doctor puts in a pulmonary artery catheter in a patient with ARDS, what will the RAP and the PAWP read? Will it be high, low, or normal in ARDS?
High?
Could you repeat that, please?
Okay, so you understand how the pulmonary edema formed in ARDS?
Mm-hmm.
Yes? You
Yeah.
understand how it formed in heart failure?
Mm-hmm.
Yeah? Okay.
Yeah.
So if this doctor puts in a Swan-Ganz catheter into the pulmonary artery, what will it read in a patient with ARDS? What will the pressures be? Will they be high, low, or
Okay.
normal?
Low.
High.
It should be not low.
In ARDS,
Low.
It should be high.
it will be high in heart failure. It says so right here.
Yeah.
Heart
Would it
failure
not
says
be
so
low
it's
there is
in
increased
ARDS?
left atrial or ventricular pressure. Okay. So it says clearly here, unlike pulmonary edema and heart failure, there is no evidence of increased pressure inside the heart in ARDS. So what will be the readings in the Swan catheter?
Then it's gonna be low.
Would it not be low?
It'll be
pressure?
low or even normal. That's how you tell. This is one of the supportive evidence that this is ARDS. This is nothing. Because when we take an X-ray, this patient's X-ray will look the same as a patient with heart failure. So they can't tell. What are we looking at? Is this pulmonary edema? What's causing this? Is this heart failure? Or is this ARDS? So one of the ways they can eliminate heart failure is to put in a pulmonary artery catheter. Get the readings inside the heart. If it's high, we're dealing with a heart failure pulmonary edema.
Unknown caller.
If it's low or normal, we're dealing with ARDS. All right, so that's what non-cardiac pulmonary edema means. And again, the patient here is unresponsive to oxygen. We call that refractory hypoxemia. I haven't seen it yet. Here, look at the mortality. And this textbook is what's the publishing date for this one? This is 20, I think this book's 4 years old, probably
15,
2015,
somewhere.
2016. Yeah, this is 2016. Look at the mortality. With all the advances we have today, we have these sophisticated ventilators, we have all the medicines today, because this number did not change from the 1900s. In World War One, World War Two, this number was the same. If anything, maybe it was 52. Okay, maybe it was a little bit higher. But look at that. With all the advances we have today, we still cannot improve or get rid of ARDS. No, we cannot improve the mortality. This is how serious ARDS is. So patient either, let's say, so this would be one of the complications from COVID as well. This COVID patient goes into sepsis, goes into severe sepsis septic shock, develops ARDS. So if they don't die from COVID, they die from this thing. So it's, although it's still COVID related, but the technical cause of death is really from ARDS. We'll skip the fibrotic phase. Management, just like in respiratory failure, your management is simply supportive. You treat the underlying cause, whatever it is. Another way, although this is not exclusive, but they do call it a hallmark sign. On X-ray, the patient's lung looks like ground glass. If you ever seen ground glass, of course, unless your glass is colored, but most glass, clear glass, when you grind it, it looks white, right? It looks like powder. So the X-ray will look like ground glass, meaning you plus it won't appear like this at one time. It'll be a series of X-rays. So you take an X-ray today. So this is what they mean by serial X-rays. So you take an X-ray today, tomorrow, the third day, fourth day, it will get worse and worse. And no matter what you do, you cannot stop it. So one lobe, first the lower lobes will look ground glass. Tomorrow it will now involve the middle lobe, and then third day it'll be the entire lung. Right? So it'll be observed in a series of X-rays, and it follows that pattern. I mean, once this thing starts, the phases will progress. There's no way to stop it. Currently, with our technology, with our treatment, we cannot stop ARDS once it starts. You can treat it early, let's say once because we know the possibility of this. Doctors can anticipate the onset, and they can treat the cause more aggressively so that it doesn't trigger the increased capillary membrane permeability, the capillary leak syndrome. That's pretty much all we can do. And here is mechanical ventilation, which we don't have time anymore. It's almost 11:45, so we'll start mechanical ventilation next week. But first we'll go to another chapter first, because we have to put in an airway first. So we'll have to intubate the patient, and that's a different set of nursing care. So we'll manage the airway, and then we'll come back to mechanical ventilation. Okay. Now the plan next week is, obviously we did not get this on the test, and I can only get to this part today. So for next week, the Thursday group, we will continue with class, and then I'll do the same for the Friday group during lab. I'll have to use lab time for lecture. Okay, so I'll do it twice. One for the Thursday group, and then another for the Friday group next week. So 2 hours should be enough for us to finish the gas exchange, and then we can continue on Friday during lecture for anemias, and hopefully also the liver. If we can't finish the liver, then I'll have to take that out of exam 4 again, and then just put them all on the final. So we'll see how it goes. We'll see what happens next week. Okay, so last quiz next week will be on PE, respiratory failure, and ARDS.
ARDS. Okay, thank you, Professor.
Thanks, Professor.
Okay.